Good morning, dear colleagues. Welcome to this 17th edition of Club APIC, an initiative of Portuguese Association of Intervention Cardiology. At Club APIC, we intend to promote pedagogical discussions of current topics in the area of interventional cardiology, our area. As president of APIC, I am pleased to announce and welcome a special guest in this edition, in this first edition of the year, Dr. Alfonso Jurado, to whom I thank you in advance for your presence and for your friendship. Alfonso is an interventional cardiology of Hospital Universitário La Paz. He has extensive experience in complex PCI and has also been dedicated to research on this field, on coronary calcification and calcium modifying techniques. I would also like to thank you for your contribution made to the training of our fellow, Ana Rita Pereira, during the past year, while she was attending her international fellowship. I know she was very well received and greatly benefit from your experience and of all your team in your hospital. So thank you for that. Now I hand over to Pedro Sousa, an interventional cardiologist and my right-hand person in APIC, who will moderate this session today. Pedro.
Okay, thank you, Rita. Welcome, everybody. Welcome to our 17th edition of Club APIC. I invite everyone to use the chat freely for your opinions or some questions that you have along the presentation. I thank again our invitees today, and I hand over the session to Ana Rita Pereira, who is going to make the presentation regarding the intercoronário laser theme. Ana Rita, good morning.
Okay, so good morning, everyone. First of all, I would like to thank the opportunity to participate in this Club APIC. I would also like to thank Dr. Alfonso Jurado for joining us today and being the discussant of this edition. So without delay, I will start with the presentation where I will talk about the role of laser in coronary interventions, focusing on its fundamental technique and application. So these slides are courtesy of Dr. Jurado. And beginning with some historical aspects, the use of laser angioplasty was first described in animals in 1982, followed by its use in humans in 1983 for peripheral disease. So although the technique first emerged in 90s and 80s, high costs and advancements in other areas of interventional cardiology lead to limited interest at that time. So only recently, there has been a renewed interest in intracoronary systems due to a better understanding of the laser tissue interface, improvements in technology and technique, and the recognition of its effectiveness in specific clinical scenarios. So here we see the data from the United States showing the increased use of intracoronary laser in the last decade. And similarly, the Spanish registry revealed a 70-fold increase in HELCA use between 2014 and 2022. So moving for the fundamentals of the technique, the currently available intracoronary laser is the excimer laser. Both laser and excimer are acronyms as also HELCA. HELCA is the acronym for excimer laser catheter atherectomy. So briefly, HELCA uses a Shannon chloride laser as the result of a high voltage electrical discharge. An excited stage is produced, the excited dimmer, and after the remission of the excitation, the dimmer returns to the basal state and liberates energy that is light energy in the spectrum of ultraviolet light. So the laser is applied in very short pulses, nanoseconds, so is pulsed laser. And these short pulses produced three main mechanisms of ablation: photochemical, photothermal, and photokinetic. So the photochemical effect corresponds to the direct fracture of molecular bonds. The photothermal effect corresponds to heat-induced tissue vaporization. So the light absorption by the plaque results in tissue vibration and heat generation, which in turn lead to intracellular water vaporization and the creation of vapor bubbles at the tip of the catheter, as you can see here. Photokinetic effect results from the rapid expansion and collapse of the vapor bubble that further breaks down plaque and also helps clearing the products of ablation. By these three mechanisms, lasers are able to modify both superficial and deep calcium. Of note, the products of ablation are really small, between 1 to 5 microns, and this is important for two reasons. One of that, the products of ablation are cleared by the reticulum endothelium system, and also the small sizes minimize the risk of distal microembolizations and subsequently slow flow or no flow. Regarding the equipment, the only currently available coronary excimer laser is manufactured by Philips. So the system consists of a laser unit or console. So this one is the new laser console, and also by several catheters. So the last version of the Philips laser is a portable unit that is smaller, lighter, and faster than its precursor. Here you can see the pedal that is connected to the laser unit and is used for the laser application. The new laser unit also presents a much simple and intuitive interface. It has a touchscreen that displays the total number of pulses applied, the total procedural time, and allows you to select the fluence and rate that are two concepts that we will discuss later. Available laser catheters include conventional over-the-wire and rapid exchange catheters. The rapid exchange version is currently the most used, and each catheter consists of several fiber optics that transmit the energy to the tip of the catheter. The catheter had a radio-opaque tip that allows and localize precisely the tip of the catheter. So 4 catheter sizes are available: 09, 14, 17, and 2 millimeters. The 09 and the 14 millimeters catheters are the most commonly used, with the 09 being the preferred catheter in the majority of cases. Importantly, both sizes are compatible with 6 French guide catheters. And of note, ELCA catheters are compatible with any O14 guide wire. So this eliminates the need for a specific guide wire. Additionally, it is possible to apply laser with another guide wire, for example, to protect the side branch, which is also different from the other atherectomy techniques. So regarding the procedure, successful ELCA procedures rely on 5 S's. So selection of patient, size of the laser catheter, setting, saline infusion, and slow advancement. So case selection is paramount to achieve a positive outcome. Currently, ELCA is used as an adjuvant tool in the PCI of complex coronary lesions, and there are 2 main scenarios in which it is used, so thrombus and calcium. The most frequent indication is balloon failure, lesions that are undilated, or lesions that are uncrossable with conventional balloons, mainly due to significant calcification. Under expanded stents, intra stents, restenosis, and CTO PCI are other indications. And the indications in the context of thrombos are restrictive to acute coronary syndromes with high thrombotic burden and saphenous vein graft PCI. There are no absolute contraindications for ELCA, but there are some relative contraindications, including acute angulation, coronary dissection, and lesions in vessels with a smaller diameter than the catheter. Regarding sizing of the catheter, so the maximum diameter of a laser catheter should not exceed 2/3 of diameter of the artery, so the ratio for laser catheter diameter, artery diameter, should not exceed 2/3. So given that HELCA is primarily used for uncrossable or undilatable lesions, a 0.9 mm catheter is typically chosen, as we previously discussed, but other reason is that this catheter is the catheter that allows us to deliver the highest fluence and the highest repetition rate. So regarding these settings, there are two parameters, fluence and repetition rate, that can be adjusted and determine the total energy applied. So the highest the fluence and the highest the repetition rate, the highest the energy that is applied. So the fluence is defined as the amount of energy at the catheter tip per unit, per millimeter square, and usually ranges between 30 and 80. The repetition rate is defined as the number of pulses emitted during 1 second and usually ranges between 25 and 80. So the manufacturer recommends beginning with the calibration setting, usually 45-25, and then increase gradually until the maximal setting if there is resistance. Some authors now start with 25-25 and then increase to 60-60 and 80-80. At Hospital La Paz, typically the first setting is 60-60 and then 80-80 if resistance remains. Regarding the infusion technique, HELCA could be performed with one of 3 protocols: the saline infusion protocol, the blood infusion protocol, or the contrast infusion protocol. The saline infusion protocol is the default or the standard approach. It offers less plaque modification power, but is associated with fewer complications. On the other hand, the contrast infusion protocol is the most powerful option for plaque modification, but comes with a higher risk of complications. So here you can see the difference of power between saline, blood, and contrast infusion techniques. With 50% contrast solution, a pressure of approximately 125 atmospheres is applied. So it is due to the formation of cavitation bubbles, as you can see here in vitro and here at the angel in vivo. And in summary, the standard protocol is the saline infusion. So blood and contrast protocols are reserved for resistant cases. And the saline technique is as follows. When the tip of the laser is near the lesion, flush the guiding catheter with saline until no contrast is visible, and then activate the laser with the pedal while injecting saline at a rate of 1 to 3 millimeters per second. Apply the laser for 10 seconds, followed by a 5-second standby or resting period. During the application, the catheter should be advanced really slowly at a rate of approximately 0.5 to 1 millimeters per second to optimize energy delivery and plaque modification. After completing anterograde runs, retrograde runs should also be performed, and there are no definite guidelines on the exact number of rains that should be applied, but it is generally recommended to perform a minimum of 2 and a maximum of 12 12 laser delivery of 12 laser runs. So regarding success rate, evidence primarily from observational studies has shown very high success rates, around 90%, and the success rates appear to be independent of the type of lesion treated, as you can see here in this study. Concerning complications, the current complication rate is really is low, around 3.5%, with coronary perforations and side branch occlusion lower than 1%. So before concluding the presentations, I will show you some clinical cases that illustrate the use of intracoronary laser. So beginning with an uncrossable lesion. So here we have a really severe and severely calcified lesion at the left circumflex. And besides the high supportive catheter and the guiding catheter extension, the lesion was not crossable with a SME-compliant 1 millimeter balloon. So laser was applied using a 0.9 millimeter catheter. Here you can see the slowly advancement of the laser catheter. And after laser application, it was possible to use to dilate with an NC balloon and implant a stent with a good final result. Here, an example of an underexpanded stent, as you can see here at the angio and here at the stent boost tool, a really underexpanded stent. IVL failed to help in this case, and for that laser was applied. As you can see here, after laser, an NC balloon was able to fully dilate with this final result. So this is the initial angio, and this is the final angio with a really good result. So to finish, ELCA is a useful technique in different complex PCI subsets. Is easy, effective, and a safe technique. Importantly, ELCA is compatible with all 014 guide wires, coronary guide wires, and it is an alternative or a complementary tool to other calcium modification devices. So now I pass the discussion to Alfonso with 3 questions. So the first one, in clinical practice, what do you consider to be the advantage of ELCA compared to other plaque modification techniques? When do you choose to use this technique instead of the other techniques? And is there scientific evidence comparing ELCA with other plaque modification techniques? So Alfonso.
Thank you, Ana Rita. The presentation is excellent as always. I want to thank you for the invitation and also express my happiness and all the team to host Ana Rita for 1 year here, because it has been an awesome year for us as well. Regarding the questions, we are true believers that all plaque modification techniques are complementary, and ELCA has some advantages compared to others. For example, as Ana Rita explained, if you compare ELCA with other atherectomy devices, for me the main advantage is that it can be used through any conventional wire, 14 wire. And it's quite important if you are doing CTOs or other complex procedure in which it's complex to cross with a wire. This is essential, and also it can be used by a 6 French guiding catheter. Also, you can protect a side branch in a bifurcation, unlike the rota or the orbital. And also another important thing is that it has some effect in thrombotic lesions, and it's not unusual to have at the same time calcium and thrombus. So if you have this scenario, probably rota or orbital are not the best options, and ELCA has some advantage. And obviously, if you compare ELCA with the balloon-based technologies, it has a better crossing profile, and it is used in uncrossable lesions, in lesions in which you cannot use lithotripsy or other modified balloons unless you use previously an ablative technology. So in summary, in which lesions I would choose ELCA? Firstly, probably in uncrossable lesions, truly uncrossable lesions in which you cannot cross even a microcatheter and exchange with a rota wire or a viper wire. And if you have in-stent lesion, peri-stent lesions, probably safer using ELCA. And if you have the third one, if you have calcium and thrombus in the context of acute coronary syndrome, probably are the three main indications for me. And about the evidence, Anna's talked something about the registries and also randomized trials performed in the 80s, 40 years ago, compared laser against rota or balloon angioplasty. It was the era previous of drug-eluting stents, but we have some contemporary registries describing the safety and efficacy of laser in different contexts, but to the best of my knowledge, the only randomized trial is the one we presented in the EuroPCR last year, and it has been accepted and is going to be published this month in JACC Interventions. It's the roller coaster trial in which we compared laser against rota and lithotripsy in calcified lesions. And it's difficult to interpret because there are three techniques. It's an intention to treat analysis, but in summary, the three techniques obtain a similar success rate, significant difference in complications, but IVL had a trend to have less perforations compared with rota and laser. And the main endpoint was the stent expansion by OCT, and we didn't observe significant differences between the three techniques after doing the corrections for multiple comparisons. So I think I answered all the questions, but I open to more discussions.
Thank you so much for your comment. I will ask only a brief question. What is the proportion of use of intracoronary laser in your center, more or less? Do you have an idea?
Proportion, taking into account the whole PCI,
Whole PCIs.
techniques, probably 2%,
2%.
not more.
Okay. Okay, we don't have any more questions. Thank you so much for your comment, and thank you so much for Ana Rita. It was a pleasure to have you today. I don't know if you want to add anything personal, any more opinion about this. It was a very complete presentation and a very complete opinion also, no?
I have
Okay,
just
so
one question, Pedro. What about the costs, Alfonso, of these equipment comparing with other ablation techniques like hot or orbital?
The cost in Spain, we have, I don't know if you know, we have 17 different organizations in the comunidades autónomas. So every city, every hospital has different agreements with the general manager. So in La Paz, the cost is similar than orbital or lithotripsy, for example. Rota is a little bit cheaper if you don't take into account the microcatheter, another wire, and everything. So probably rota is a little bit cheaper, and ELCA is similar, it's 2,000 euros, more or less, similar than lithotripsy and orbital. And the thing is, you have to for having the console, you have to take the compromise to perform a number of procedures, and probably you need to perform also peripheral procedures and lead extraction that are the other two things that ELCA can do. So probably you need an EP team or cardiac surgeon team or vascular team that also shares the machine.
Okay, thank you.
Thank you. I don't know if there is any other questions that anyone wants to make. If so, if not, thank you so much, Ana Rita, Alfonso, for being with us.
Sure.
So I will finish in Portuguese. Chegamos ao fim da 17ª edição do Club APIC. Agradeço a presença de todos os participantes, em especial da doutora Ana Rita Pereira e do doutor Alfonso Jurado, do Centro de La Paz, por terem aceito o nosso convite. Recordo que esta iniciativa se repete na primeira quinta-feira de cada mês. convidamos a estar presentes na próxima edição do Club APIC, na primeira quinta-feira de fevereiro, dia 6. Bom dia a todos e continuação de bom trabalho. Muito obrigado.
Yeah, thank you.
Bye bye. Thank you.